Good morning, everyone. So I was asked to speak about IPI 145. We've heard a lot already at this meeting about how the PI3 kinase serves as a nexus for many different signals to B cells. And as you know, it consists of a P85 regulatory subunit and a P110 catalytic subunit. So far, we've been focused exclusively on the delta subunit, which has expression limited to leukocytes and a knockout animal phenotype focused primarily on B cell signaling, development, and survival. Now I'm going to ask you also to consider briefly the gamma isoform, which also has expression limited to leukocytes, a benign knockout animal phenotype, but in this case it affects neutrophil and T cell function. I would also like to remind you, courtesy of Amy Johnson in this slide, that all isoforms are expressed in CLL. So delta and gamma are both expressed. So that brings us to IPI 145, which is a potent dual inhibitor of delta and gamma. And you can see the KD for delta is 23 picomolar and about 10-fold less potent against gamma. And in whole blood assays, the delta IC50 is in the low nanomolar range. So the initial phase 1 study was designed as shown here with a dose escalation from 8 milligrams BID up to 100 milligrams BID. And the plan was for cohort expansions at the MTD in a variety of diseases, CLL and low-grade lymphoma, diffuse large B-cell lymphoma, and also in T-cell lymphoma, ALL, and myeloproliferative neoplasms, the T-cell and myeloid diseases related to the gamma activity. However, it was also decided that there would be expansions at 25 milligrams BID in the CLL and the indolent lymphomas. And this was based on PK/PD data that I'll show you in a minute, showing continuous suppression of the delta isoform at doses of 25 milligrams BID. And there was concern that higher doses would result in increasing inhibition of gamma and that might be associated with infectious toxicity. In addition, clinical responses were seen at the very low doses, 8 to 25 milligrams BID, in CLL, indolent lymphoma, and mantle cell lymphoma. So here is the PK profile. It's characterized by rapid absorption and a moderate half-life of about 6 to 10 hours. And you can see the 25 milligram BID dose is in blue. And at 8 hours, it's still above the IC90 for delta and at about the IC50 for gamma. And so that's the dose that's moving forward in CLL, although higher doses are being tested in more aggressive diseases. You can see the IC90 for gamma up at the top on the graph. So in the very early report of the phase 1 study, 11 patients with CLL were reported after 2 cycles of therapy. And this looked quite promising, 3 partial responses and 6 nodal responses, so 9 of 11 total responses. And the typical pattern of lymphocytosis that we see with all these agents, and a suggestion of rapid resolution of that lymphocytosis, at least in this patient here. And so then these data were updated at ASH this past year by Ian Flynn, who supplied these slides. The dose escalation phase of the study completed. At 100 milligrams BID, there were 2 dose-limiting toxicities. One was rash, and the other was grade 3 transaminitis. And so 75 milligrams BID was selected as the MTD. And so in terms of CLL patients, we have 2 relapsed refractory cohorts, some treated at the 25 milligram BID dose going forward or less, others treated at 75 milligrams BID. And then they opened a treatment-naive cohort at 25 milligrams BID that had 15 patients enrolled at that time. And that naive cohort was restricted to patients over 65 or with 17p deletion or p53 mutation. So the patient characteristics are shown here. Age is fairly typical for our CLL patients. The relapsed refractory patients had a median of 4.5 prior therapies, and 61% of them were less than 6 months since their last therapy. Half had bulky adenopathy, and 53% had 17p deletion or p53 mutation. So pretty heavily pretreated patients. There are also 4 patients with prior BTK inhibitor therapy, but it wasn't commented what their responses were. So in terms of patient disposition, the follow-up was still very short at this time, about 5 months in the relapsed refractory cohorts and 2.7 months in the treatment-naive group. And you'll note that in the relapsed refractory cohorts, about 50% of patients had discontinued treatment already at this 5-month or so median time point. And much of this was due to adverse events, which are enumerated at the bottom. Many of them are pneumonitis. There's a case of transaminitis, a case of PJP, diarrhea, and also a grade 5 sepsis. In the early dose escalation phases of the study, there were some opportunistic infections that seemed a little more than one might have thought, including HSV pneumonitis, for example. And so prophylaxis was subsequently mandated in the protocol. If we look at the overall adverse event profile for the whole population, it looks fairly similar to what we're seeing with other molecules. In the relapsed refractory patients, we do see grade 3/4 neutropenia, but again, that's fairly typical. The other with idelalisib, for example. 6% grade 3 diarrhea, and 6% grade 3 transaminitis. In the treatment-naive population, the adverse events look pretty clean. And this is the adverse events of grade 3 or greater. Again, looking pretty good, except neutropenia, as we expect in the relapsed refractory. And infections, even in the relapsed refractory, about 15%, although there was the grade 5 sepsis. This slide looks at AKT phosphorylation as a pharmacodynamic marker at both the 25 and 75 milligram doses, and shows excellent inhibition. This is the waterfall plot for the patients reported at ASH. And you see that 98% of patients had some reduction in adenopathy in the relapsed refractory group, and 89% of those dosed at the 25 milligram BID or below dose had a nodal response, meaning at least a 50% reduction in adenopathy. The treatment-naive CLL patients are just extremely early. Thus far, they reported nodal responses in 3 of 6 patients, including 2 with P53 mutation. If we look at the clinical responses, the response rate by IWCLL is 47 to 50%, and this is independent of the 25 or 75 milligram dose, and also appears to be largely independent of the 17p or P53 mutation. And so we have a nodal response rate of about 90%, a IWCLL response rate of about 47 to 50%. I assume most of the difference was due to ongoing lymphocytosis at the short follow-up point, but that wasn't actually mentioned. And this slide shows the time on study for the relapsed refractory patients. There are a number of long-term progression-free patients, a number recently enrolled with short follow-up, and then some discontinued at the bottom, where, again, issue of adding infection prophylaxis, for example, might have helped keep some of those patients on study. 6 of the 8 patients treated for a year or more remained progression-free on treatment. So in summary, IPI-145 is a very potent PI3K delta gamma inhibitor, and it has moved into a phase 3 registration trial in CLL. This is IPI-145 versus ofatumumab. I think the impact of inhibiting gamma in addition to delta is still unclear, both in terms of toxicity and efficacy. And we probably need much larger studies to understand that. The drug shows very high nodal response rates in its early data. Rate of resolution of lymphocytosis is poorly defined, although, as we've discussed at this meeting, lymphocytosis is not really a clinical problem. And then the tolerability with long-term dosing is a bit unclear, as we did have 50% of patients coming off at the median of 5 months. But again, that included patients prior to the optimization of prophylaxis. So we'll need longer follow-up on that as well. Thank you.